Welcome to the first of 4 lectures in Team 5's lecture series on phenylketonuria. After completion of all 4 lectures, you will be able to summarize the common symptoms and clinical diagnosis of phenylketonuria, or PKU, describe the pathophysiology of PKU and the importance of early diagnosis, recognize laboratory goals of phenylketonuria and health consequences if these goals are not maintained. Determine appropriate food sources to meet nutritional needs of pediatric PKU patients and identify nutrients at risk for deficiency. You will also be able to identify high phenylalanine food sources and ingredients and create a nutritionally low phenylalanine diet from a clinical presentation. Our module is divided into 4 lectures, and you can see here what will be covered in each of the lectures. In this lecture, we will discuss an overview of PKU, as well as the prevalence and common symptoms of the disorder. Phenylketonuria, or PKU, is an inborn error of metabolism. An inborn error of metabolism is an inherited disorder in which the body is unable to properly metabolize food. PKU is classified as an amino acid disorder, which is a defect in normal amino acid metabolism. In cases of PKU, the specific gene affected is the PAH gene, which is responsible for making phenylalanine hydroxylase. In typical conditions, this enzyme converts phenylalanine to tyrosine. Without this enzyme, phenylalanine builds up in the blood and body tissues, which can lead to dangerous cognitive consequences. PKU occurs due to autosomal recessive pattern of inheritance, which means that both parents must be carriers of the defective gene and pass it to the child. It's also the first inborn error of metabolism in which dietary intervention has been successful, which is so important to us as future dietitians to be aware of the importance of nutritional intervention in persons with PKU. Reviewing phenylalanine as an amino acid, it's found in high-protein foods such as beef, pork, chicken, fish, eggs. It's also found in cheese, beans, nuts, and starches. And it's important to remember that it's found in the artificial sweetener aspartame. Care for the disease includes strict dietary management, and persons with PKU must avoid foods high in phenylalanine, which is essentially avoiding high-protein foods. The prognosis, though, for infants that are diagnosed with PKU is good as long as the strict low phenylalanine diet is initiated shortly after diagnosis, as delaying treatment can result in brain damage or other unwanted symptoms by the end of the first year of life. Remember, PKU is a lifelong condition, and it requires lifelong care and management. PKU is found during newborn screening. In the United States, it's a federal mandate that all 50 states have newborns screened for a variety of disorders. One of those is PKU. So every baby that's born in the United States should be screened for this disorder. Now, it is possible to opt out of the screening, and you have to sign a waiver citing religious reasons for opting out of the screening, but that's relatively rare, and so most children will be screened for that variety of disorders, including PKU. Screening takes place 24 to 48 hours after birth, and it generally takes place by way of a heel prick. In the picture on this slide, you can see a baby receiving the heel prick right now, where the heel was pierced to allow blood to flow, and the blood is then pressed onto the cardstock, and there's a pretty decent sized circle that must be full of the baby's blood in order for the heel prick to be considered successful. We wait 24 to 48 hours after birth to do the newborn screening so the baby has had time to ingest protein prior to the test. And a second screening will take place at the baby's pediatrician's office or general well checkup, which is around 2 to 6 weeks old. So there will be 2 newborn screenings done in order to ensure that these inborn errors of metabolisms are not present or are present. But after the screening results come back positive for PKU with high serum phenylalanine levels, additional blood and urine tests will be run to confirm the diagnosis, as an initial out-of-range reading does not automatically mean that the child has PKU. It's also possible to do testing in pregnant women on the unborn child to determine if PKU is present, so that way we can be aware of the diagnosis before birth even takes place. We're going to get more in depth with diagnostic criteria and screening serum levels in Lecture 3. So right now, let's just remember this overview on how diagnosis occurs. And remember too that because newborn screenings allow for early diagnosis and treatment, severe signs and symptoms of classic PKU are rarely seen in this day and age. Genetic testing can also be conducted to determine if a person is a carrier for the PKU gene. The incidence of carriers of the PKU gene is 1 in 50 in the general population. If both parents are carriers of the gene, the risk of having a child affected by PKU is 1 in 4. And that is the case for each pregnancy that the couple may have. So no matter how many pregnancies they have, how many kids with PKU they have, each pregnancy has an equal 25% chance of developing PKU when both parents are carriers of the gene. There's about 1 in 10 to 15,000 babies born in the U.S. with PKU, and it's estimated that there's currently around 16,500 individuals living with PKU right now. Remember that PKU is not affected by gender. Male and female develop PKU about the same, and it is more prevalent in individuals of Irish, Northern European, Turkish, or Native American descent. And it's less common in the Jews of Ashkenazi ancestry and in African Americans. Infants born with PKU will typically appear normal at birth, and signs of classic PKU will likely be absent. Untreated or undiagnosed infants will begin to exhibit symptoms around 6 months of age, and they might present with weakness or difficulty feeding. Lethargy or being abnormally drowsy are also signs that might be seen. Symptoms can vary from mild to severe, and individuals with PKU are not all affected to the same degree, and they will have different treatment plans. It is a spectrum disorder, so there will be a large amount of variance in between individuals with PKU. The less severe forms of PKU include variant PKU and non-PKU hyperphenylalaninemia. Individuals with these types might have less strict dietary restrictions. Classic PKU is the most severe form, and it can result in severe cognitive and intellectual disability if it's not properly treated. And that's why it's so important for early screening and diagnosis and treatment to occur. These individuals with classic PKU will be the ones with the most strict dietary plans. On this slide, we can see a list of the common symptoms that are associated with PKU. Some, if not all, will be present in individuals, and many of the symptoms are neurological, and those can include seizures, abnormal gait or poor coordination, aggressive behavior, and hyperactivity. In these individuals, phenylalanine cannot convert to melanin, and so which is the pigment responsible for hair and skin tone, and that's why fair skin, hair, or eyes is a common symptom of PKU. Another symptom that might be smelled is a musty or mousy body odor, and that comes from the skin, the breath, or the urine. It's a result of the byproduct of phenylalanine, which is phenylacetic acid. Now let's move to the fictional story of baby Sadie. In the case study section of Portfolio, you're going to get pretty in-depth with Sadie's circumstances and discuss her treatment specifically. We're also going to follow her in each of our lectures, so let's see what we can learn from her today. Sadie is the 16-month-old youngest child of Greg and Lisa, who have 2 other children. Neither of them have PKU, but baby Sadie was diagnosed with phenylketonuria. After her diagnosis, the pediatrician and the registered dietitian discussed the dietary management that Greg and Lisa would need to do with baby Sadie and how it would follow her for the rest of her life. She was given a special infant formula free of phenylalanine, and they pretty closely adhered to the recommendations for the first year of her life. But yet, at her first birthday, they decided they really would like to move her and transition her out of this diet and kind of transition her to foods in the same way that they had their other children. They had already started giving her foods from around 6 months and hadn't seen any kind of symptoms that they noticed. So they decided to forego the special formula and just transition her to foods as they wanted to. But at her 15-month pediatric checkup, then the pediatrician heard a few things of concern from Lisa, specifically that she gets pretty hyper and clumsy sometimes, that she wasn't meeting milestones the same way as other kids her age or even her older brother and sister did at their age. There was a rash present, and there was a little bit of concern on Lisa's part about baby Sadie. So the doctor checked Sadie's serum phenylalanine levels and discovered that they were high, and that's when he found out that the diet had not been closely adhered to for the past 3 months, and that he was seeing symptoms of high serum phenylalanine levels. So he sent them on to you, the registered dietitian, to get some further diet counseling about how they can adhere to this diet at the age that Sadie is currently. But let's discuss Sadie's situation according to what we've already learned today. Discuss what likely took place for Sadie to receive the PKU diagnosis. Pause the lecture if you need to, go back and look in your notes, and remember what we talked about had to take place for a diagnosis to occur. Welcome back. For a diagnosis to occur, the initial screening had to take place, which took place either at the hospital or the pediatrician's office at 24 to 48 hours after birth, and then around 2 to 6 weeks. One of those screenings, likely the first one, but one of those screenings would have revealed higher phenylalanine levels in the blood, and that would have led to subsequent testing, which would have confirmed the diagnosis. Remember, a diagnosis does not occur just due to the first abnormal result, that there will be more specific testing done in order to confirm the result and confirm the diagnosis. So let's talk about how Sadie is the third child and her older brother and sister do not have PKU. How does that impact the likelihood that she's the one that developed PKU instead of them? Pause your lectures, look at your notes, do what you need to do in order to come up with your answer for that. And maybe you remember it doesn't. It doesn't impact the likelihood of Sadie being the child that developed PKU just because she's the third child. Each of Greg and Lisa's children had an equal chance of developing PKU, which is a 25% chance. Greg and Lisa might want to keep note in the back of their mind that because Sadie has PKU and because they're carriers for PKU, perhaps Sadie's older brother and sister might also be carriers. But that's just a note for future reference and not relative to our understanding right now. Thank you for listening. Continue on in Lecture 2 as you're ready.